On behalf of CHCI, I'd like to thank Amgen, AstraZeneca, Genentech, Grail, and Walgreens for their generous support of this session. It is now my pleasure to introduce welcoming remarks from Charlie John, Director of Healthcare Policy and Strategy for Walgreens. Charlie has been with Walgreens for 24 years, 12 of them as a pharmacist. He's worked to improve access to healthcare through pharmacy by championing the role pharmacists play with medication counseling, adherence, disease state management, and immunizations. He was also the recipient of the National Minority Quality Forum's Leader in Health Award. His work involves engaging with public officials and industry and community leaders around healthcare policy in efforts to improve the administration, equity, and outcomes of our healthcare system. Give it up for Charlie.
Good afternoon. As Matthew stated, my name is Charlie John. I'm the Director of Healthcare Policy and Strategy at Walgreens. I'm honored to be with you this afternoon and looking forward to engaging discussion today about preventing, detecting, and treating major diseases. A critical piece to improving health outcomes is access, and the pandemic has given us at Walgreens an opportunity to show that pharmacists and pharmacy team members play a crucial role in expanding critical access to care and improving health equity. The impact of chronic conditions is significant, as approximately half of the U.S. population suffers from at least one chronic condition. And this is heightened in the Hispanic community, where we see elevated incidence of conditions such as hypertension, diabetes, and depression. Add to this that Hispanics are somewhat less likely than non-Hispanics to see a physician. Recognizing this, Walgreens is uniquely positioned to help drive better outcomes and lower overall healthcare costs, as our vision is to be the leading partner in reimagining local healthcare and well-being for all. Through our strategic partnership with VillageMD, Walgreens is the first national pharmacy chain to combine the expertise of the physician and the pharmacist to uniquely impact the patient care journey continuum. Additionally, we've launched our Walgreens Health Platform in the last year, a technology-enabled care model that will bring equitable and personalized health care to local communities across America, whichever, wherever, and however the consumer chooses. This all builds on the core of what we do, and that is the services our pharmacists provide every day to those living with chronic diseases, help better manage their health through meaningful clinical conversations that increases patients' medication adherence and reduces overall healthcare costs for conditions like asthma and diabetes. This is in addition to the health services that many have come to use and need from our pharmacists over the last 2 years, from COVID testing to immunizations to therapeutics. Moving forward, it is vital that the access to these services remain, and that is why we support policy efforts such as the recently introduced H.R. 7213, the Equitable Community Access to Pharmacist Services Act. Bipartisan legislation, including the co-sponsorship of Congresswoman Barragan, that would ensure patients continue to have access to essential pandemic-related health services provided by pharmacists. So thank you, CHCI, and our panelists for exploring this issue. I'm looking forward to the discussion and learning how we can all work together to advance access and equity to healthcare and improve outcomes for all. Thank you.
Thank you, Charlie. It is now my pleasure to introduce today's moderator, a man who needs no introduction, the President and CEO of the Congressional Hispanic Caucus Institute, Marco Davis.
Thank you, Matthew. Thank you, Charlie. Thank you, everyone, for joining us here today. It's my pleasure to be here with you and to help manage this important conversation about this really crucial issue, this idea of identifying, of treating, of innovating in trying to detect and treat major diseases in the community, as was mentioned. We have a very distinguished panel here with us today, so I'm going to introduce our experts. So first we have Raquel Racadio, who is the Director of Representation and Clinical Research at Amgen, where she leads a team that is dedicated to improving the global diversity and proportional representation of patients from historically excluded groups in Amgen's clinical research programs, a really important role. Raquel has nearly 15 years of experience in clinical research in the life sciences. Her background also includes public health research, which has consistently focused on racial, ethnic, and gender disparities in healthcare access and health outcomes. Welcome, Raquel.
Thank you.
Absolutely. Next to her, we have Dr. Michael Del Aguila. Michael is an epidemiologist with 25 years experience in research to understand the benefits of novel technologies and treatments in clinical practice. His research spans many chronic diseases and populations, so he's going to have a lot to share with us today. At Grail, he is focused on generating real-world evidence to understand the population benefit of screening for cancer through a blood test. This has the potential to address health equity issues associated with race and ethnicity and access to care. Welcome, Michael. And farthest to my left, your right, we have Dr. Veronica Sandoval. Veronica is principal in the Patient Inclusion and Health Equity team in the Chief Diversity Office at Genentech. Veronica's policy and medical background, along with the personal and professional intersection of her Latina and health equity efforts, bring a rich perspective to Genentech's ongoing work in health equity and inclusive research. She has over 7 years' experience in medical affairs and has supported different therapeutic areas. She also practiced as a litigation attorney focused on complex patent litigation in the life sciences and pharmaceutical fields. So we have a double threat in medicine and law. So welcome, Veronica. And just want to remind you all as we get into the conversation first that we are recording this session. It will be made available online in about a week for all of your peers and colleagues for you to review the pertinent and important comments that we hear today and to share with colleagues and peers who weren't able to join us today and who may not be located in Washington, D.C. And of course, throughout today's discussion and the rest of the day, please do feel free to tweet and share your comments about these conversations we're having using the hashtag CHCI Summit. There's been lively conversation already over the last few hours, and we hope to see it continue. So now, let's get right into our conversations. Let me ask you each first if you could share, as folks often say in these days when they begin conversations, what is your why? What got you into the work? What motivates you? What inspires you, hopefully, to do the work that you do? And maybe we can start with you, Raquel.
Sure, thanks. So there's you heard that whole bio and everything about me, which is a big title and things about what we do as work. But underneath all of that, I really identify with being a first-generation American. I am a brown-skinned daughter of immigrants that came from a developing country, and I work solely in this work now. Now, we've seen a lot of, the things that can happen when you are someone like me, right? You experience things about being less than, being different, the way that people treat you. And we've seen a lot more of that, right, in the recent past with racially and ethnically driven divisions and violence, I'm sorry to say. But I also come from a family of first-line healthcare professionals and community health advocates who've really taught me the power of passion, the power of using your strengths and your privileges to help others and to advance health equity. We've already talked about my public health background, but that's really driven what I do and what I do now full time, which is really great that I get to work in living my why and helping to advance the representation of all groups across our clinical trials, but specifically focused on racial and ethnic minorities. So lots of things to drive me there, but really happy to be here because this is part of the why.
Great, thank you. Michael.
Well, first of all, thank you very much for the opportunity to be here and to present and speak with all of you. Like many of you probably, I also was born and raised outside the United States. I was born in Peru and raised in Peru and Ecuador, and came up here permanently to live when I came to university. So my father was somebody who was from the very far interior of Peru and had actually one of those immigrant stories that came up and was able to learn and become an educator here in the United States. And he and my mother both gave me that ability to understand why education is so important and the benefit that it can bring to all of us. And it also helped me appreciate the fact that we need to be constantly asking questions to seek to understand why people are different than we are and what their perspectives are, and be as much as possible able to speak with them and address the questions that they're most concerned with. So after getting a degree in epidemiology, I was able to focus on a lot of those same issues from a chronic disease perspective to understand that we can have all of this education, we can have all of this knowledge, but if we're not engaging with the people who ultimately will benefit the most from it, it doesn't do them any good. And it's as though all of the learning that we have is falling by the wayside. What attracted me to Grail very specifically here is that we have this technology that through a simple blood draw has the ability to change the detection of cancer at a much earlier stage when we know that the survival rates are much higher and the treatment costs are a lot lower. And something like this seemed like it could really revolutionize the way that we go about identifying cancer and treating it. But if it's not made available to the people who can benefit the most from it, again, it's as though it's falling, by the wayside and it's not being taken up. So what really attracted me to GRAIL was to say, if we can generate programs where we're extending the research to people who may not have participated in it at this point in time, and make this technology available to them using means of communicating the benefit for them in language that they'll appreciate, the impact can be that much greater. I'm in my mid-50s, and I have two friends, one of whom has passed away because he was not able to get early screening for colorectal cancer, and it was just diagnosed too late, and he ended up dying shortly afterward. And another one who is still alive after having an X-ray detect a little bump in his lung after being treated for kidney stones, and they were able to diagnose stage 2 lung cancer, and he successfully underwent treatment for it. So for me, on a very personal level, it helps me understand that if you're able to detect cancer early, you're able to actually make a much bigger difference for that. That's why I'm here at GRAIL, and if we're able to do something like this for the Hispanic community across the United States, I think the tremendous opportunity is there, and that's something that's really I'm eager to undertake. So thanks again.
Thank you for sharing that, Michael. We appreciate it. Veronica.
Gracias. First, thank you, CHCI, for the invitation. And like my colleagues up here with me today on the stage, I'm going to say I'm Mexican-American, a proud Chicana from California. Grew up in a small Mexican community of farm workers. And being very, a proud daughter of immigrant workers, the one thing that has been embedded in myself and my siblings is hard work. And I think everyone appreciates that in this room. And why am I here today? I'm here because I want to represent not only the work that Genentech does in advancing the biomedical research that we do, and the importance of bringing medications and access to medications to our Latino community and our patients of color. And I'm here because I want to give a voice to my family. Those immigrant workers that even through the pandemic, when we were listening to the news, those farm workers were the essential workers that fed us. However, when we talk about clinical trials, they're the last people that get access to those clinical trials. They're the last people who are asked, do you want to participate in a clinical trial? And even if they're asked, I don't think as a community, we understand the importance of why we should participate. So my goal is, through CHCI's platform, how do we come together and work together to actually educate our Latino community and really make them understand the importance of why we need them to participate in clinical trials and what this means, not only immediately for us as a community, but for the future of our community in this country. Back to you, Ruby.
Thank you, Veronica. Appreciate that. And actually, I want to jump off from that last point you just mentioned. I think you make a really excellent point about the need to help educate and inform our community about the value and importance of participating in clinical trials. And we know that our communities are underrepresented in clinical trials. And I'm wondering, from each of your perspectives, from the vantage points you all are in and the work that you do, what are some other examples of success, of best practice, right? What would good practice in preventing, in detecting, and in treating some of these major diseases look like? What are the other kinds of things we need to do in addition to informing folks about the need to participate in clinical trials? Are there other aspects of of how you envision how this field should function that would be useful for folks to know? Anybody want to jump in? Any order?
I could jump in, that's okay.
Great.
I'm ready for that. No, one of the things that it's always important, and I'm glad that we're here with CHCI because we have a vast representation, not just from industry, but also policy and legislators. And, one thing that is very important is giving access to biomarker testing. When we talk about Latinos and look at the different cancers that our Latino community faces, from colorectal, breast cancer, liver cancer, we do not have enough policy in place to actually give access to biomarker testing. All of these cancers that I mentioned actually have guidelines, that say biomarker testing should be a part of that overall patient treatment. But yet, our Latino community, I don't have to say, they're underinsured or not insured at all. States, when we're look at states, where do our Latino communities get their coverage from? Medicaid. Medicaid does not cover biomarker testing. So when we're talking about how do we make sure that we put a platform and actually give access to that healthcare that our Latino community, and to be frank, underserved communities, if you do something for the Latino community, that's going to serve the Black community, the Asian community, and the underserved. We really need to, and with your help, we need to push for that policy at a state level and also with private insurance companies, because that's how we're going to give access to our patients.
I think I'll add to Veronica's just bringing up screening in general, right? Osteoporosis is another really good example of this. We know that Hispanic women are over 30% less likely to receive a DEXA scan. It's super important to understand their level of disease versus non-Hispanic white women. And this is a problem, right? Because CMS has actually cut reimbursement rates for physicians who perform DEXA scans in their clinics by over 70%. So there's been a disproportionate impact on Hispanic patients in hip fractures, in hospitalizations, and death rates. So it's really important when we talk about innovation in screening that we're also talking about policies that allow for that access, because developing innovation is one thing, right? But developing it that is intentional and thoughtful through inclusive research that takes into consideration the needs of the Hispanic and Latino community specifically is how you get to be a sustainable policy, a sustainable way of doing research. That's why bringing it to where Hispanic and Latino patients live and work is especially important. And one of the things that we're doing, particularly at Amgen, is taking a page of the community-based participatory research. There may be some of you already in the audience that are from the public health, community health world that know this term. But within industry, it's not one that's necessarily applied to the way we do clinical research. And why it's important is because it takes the perspective of community members, puts that at the center, and co-creates solutions with them, policies with them. The way that we answer research questions with them, is their participation is central to the way that we do research. So that's something that we really want to apply to make sure that what good looks like that when it comes to research.
Yeah. I mean, I would add to that it needs to almost be sort of a pincer-like approach where, on the one hand, you're trying to change the policies to make these new technologies and innovations available. So at GRAIL, we are not sponsoring, but we're supporting a bill that's, that's out there. What is it? HR 1946, which is the Medicare multi-cancer early detection screening test, in support of doing all of that. And so we're supporting the legislative efforts that will make these these technologies available. But we're also then participating with federally qualified, healthcare centers that are enrolling and working with patients who themselves may not necessarily have a lot of experience engaging in clinical research. And so it's important for us to extend a little bit more effort and time to work with these organizations to provide us with regulatory grade and high quality research that actually reflects the realities of the patients who they're treating, who can benefit the most from all of these. And therefore conduct the research to understand how it's going to impact these patients, and then provide the framework through which they may have access to these because of the policies that would exist to bring these screening technologies to them as well. It requires a lot of time and effort. It's not fast, and there's a lot of learnings that we have to recognize that when we come in thinking these are the ways that things should come about, it doesn't necessarily reflect the reality of the people who are participating in these healthcare centers. But if we can have the dual approach to doing that, we think that will largely result in a sustainable benefit.
That's great. And we've mentioned a few things like information and knowledge about the importance of participating in clinical trials and access. We've talked about cost. We've talked about reduced access to, for example, some of the screening mechanisms and so on. I'm wondering, what are the other, and are those the largest, or are there other barriers? What are the biggest challenges, the hurdles we have to overcome as a Latino community in order to improve the overall community's well-being in these areas? Are there things that stand out, or are there things that folks might not know that we should be focusing on our attention, whether it be resources, investments, whether it be policy, or changing behavior?
This is a little bit more detailed when it comes to, particularly the Hispanic and Latino medical community, but there is a lack of awareness, not just of the lack of representation in clinical trials and what that contributes to sort of a limited data set of safety and efficacy, but there's also a lack of awareness on the part of many researchers and HCPs in the amount of diversity and heterogeneity in the Hispanic and Latino community itself, right? We already know this, right? There's over 20 countries of net nations of origin for people in the United States. So it's really hard to generalize some of these data sets that we have, some of the research that we have, what we kind of know, if we don't really localize that approach to research in healthcare. It's specific to how we can do things a little bit better. Obviously, we have to start the Hispanic Latino community largely, but being able to localize and focus in more on that actual diversity within the community is something really important to overcome.
And I think there's always going to be, I mean, for any of us, anytime there's something new and innovative, which is essentially what we're talking about here, there's a level of unfamiliarity from the practitioner's perspective as well as from the patient's perspective. And if you have something, so in the case that we're talking about, just because this is what stares me in the face every day, if we think of a simple blood test that can help detect all of these different cancers, that sounds a little bit strange and frankly crazy to people if they're not familiar with this and how it should be done. And to the extent that they weren't involved in the process of developing it, they're less familiar with it, we have to take that extra step to help them understand this is why something like this could actually benefit you. And it still represents somewhat of an intrusion into somebody's life, but how do we actually make them understand the real benefit for this? And that involves educating the providers, educating the healthcare system, and educating the patients, who haven't necessarily been involved in this all along the way. And it takes extra effort, and to the extent that we haven't done this from the very beginning, we have to play catch up ourselves to understand, okay, how do we translate what we've currently done to make it more really usable by the people who are ultimately going to be able to get the potential benefit from this?
There's also an element, right, in addition to that education is the caregivers and the family members, right? Hispanic and Latino communities, along with many other communities of color, a lot of those decisions are made by our families, right? So that education should also be tailored for caregivers and family members that will help make some of those decisions.
Yeah.
And I just wanted to add, a comment on everything that, Raquel and Michael have been talking about, because it comes down to public health literacy.
Yeah.
Right? And, as an industry, and we have 3 representatives up here, I think that all of us are really trying to figure out what is it and how can we do public health literacy? Because that goes across, not only from patients, but your providers. And when we're talking about who is treating our Latino community, Genentech is a specialty company. We're talking about oncology, multiple sclerosis, Alzheimer's, right? But who is it at the forefront? It's our primary care physicians, our family doctors. And if that family doctor at the FQHCs or at the private clinics are not comfortable with what the technology is, they're not comfortable with what a clinical trial is, they're that first barrier. I've heard a lot from our FQHCs that say, I don't offer clinical trials to our Latino patients because I don't want drugs to be tested in my community. That is something that we need to change, right? And even when I was talking about biomarker testing, at Genentech, we're partnering with the American Cancer Society and Cancer Action Network, because that is an association that actually is taking the lead in educating our legislators and regulators on the importance of biomarker testing. So it's partnerships. How do we build those partnerships with legislators, with third-party organizations, with patients themselves? Because the key is you need to activate the patient. The patient has to understand their role in their patient journey. And I think that's a huge barrier and challenge that all of us are trying to figure that out.
A lot to think about, a lot to navigate. And, we've been talking, the focus, the topic, the theme of this conversation is about the major diseases, the chronic diseases that our community already faces, right? We're talking about cardiovascular disease. We've been talking about cancer, about diabetes, about Alzheimer's, all these things that have devastated individuals and families in our communities for quite some time. And thank you all for sharing that you all and your corporations are making efforts to address these, and you all, your individual efforts to challenge and to address and to improve conditions for our communities through specific initiatives. But we would do a disservice to this conversation if we simply talked about this without acknowledging the current reality, or shall we say the last couple of years' reality, right, which is the COVID factor. There were lots of conversations. I remember a fair amount of news coverage that talked about the fact that folks were postponing treatment, right? That folks, you know, and when we, in 2020, folks were in fact, prevented from even having medical visits, right? There were procedures that were postponed. And then, of course, we've got a healthcare shortage because of so many frontline essential workers, et cetera, et cetera. So I'm wondering, what are your insights? What are your thoughts? What can you share in terms of how we're navigating this already difficult terrain with this added complicating layer? How have you seen that play out in Latino communities? What have been some potential responses that people can look at, or at least what do we need to be aware of as we continue to sort of see these very alarming trends and statistics in the Latino community?
So cardiovascular disease, you mentioned, I'm going to use that as an example, right? Because it's one that we know that's chronic. It disproportionately affects Hispanic and Latino communities. But I want to start kind of with this concept of innovation, right? When we talk about innovation in diabetes, hypertension control, we know that it actually decreases the prevalence of cardiovascular disease. And it's actually averted additional COVID-19 deaths. Some estimates show this to be, about a 30% decline in ones that could have been due to cardiovascular disease. So this really highlights that an investment in innovations in chronic disease, as well as access to treatments, is really critical to control chronic diseases, but also to mitigate any impacts of future pandemics that may or may not happen. We should be ready for it. On the flip side, you had mentioned this already, the pandemic showed a decline in cardiovascular health screenings, which led to people not visiting their providers, less cholesterol screenings, somewhere in the neighborhood of over 35% of less cholesterol screenings, as well as less primary care visits, which really led to some of these things we're seeing in cardiovascular disease. So that's how we have to treat cardiovascular disease inequities and other disparities in health, is really an emergency as a crisis really to deal with, right? Because the focus on advancing health equity for Hispanics and Latinos through access and through screening and through treatment can really help us understand how to more manage those chronic conditions within the community, but also make us more prepared for any impacts that might come from a pandemic like the one we're experiencing now.
Yeah, and I think it's true. So in oncology, for instance, we know that the screening also has gone down considerably, as during these past couple of years with regard to access to care and the perception that either you couldn't get in for screening or that there were other things relating into your life to give you access to health care. On top of that, we know that deaths from screened cancers really only accounts for about 39% of all deaths from cancer. So there's a tremendous unmet need, even above and beyond whether you're getting access to care. And of course, there's a socioeconomic gradient with regard to the people who are most likely to be able to come in for cancer screening in the Latino community in the United States. And so again, if there's a way to reach out and help people, first and foremost, have broader access to doing all of that, I think it is incumbent upon us to understand what we, are, from the industry perspective, to understand what are some of the challenges about that, and then really trying to address that, whether it's through making the technologies available more broadly, but also understanding that the kind of outreach to the communities that we can do. And we try to do that at GRAIL in terms of, again, working with some of these healthcare systems that are treating some of these underserved patients. But there is, it continues to be an ongoing challenge. And it's, I'm wondering how all of this will sort of bounce back and what sort of new equilibrium will be in place after the pandemic begins to subside and we come to a sort of new normal and a new stasis. But the need is clearly obviously there, and we're very focused on trying to be able to bring our technologies to as many people as possible who don't currently have access to them.
One thing, and this is my recurring theme, and you're going to be like, that Veronica woman keeps coming back to this, but I think it's important, right? And it's that public health literacy piece, right? One thing that we know, for example, diabetes. If I were to say, show of hands, how many of you know a diabetic? I'm sure all of us would raise our hand. Right? But the one thing that we know at Genentech is, we're working on diabetic macular edema. Right? And that is an eye problem. You're losing your eye vision because of diabetes. However, our diabetic patients, especially our Latino patients, they know that they have to check their kidneys. They know to ask about their A1C level. They know about the risks. They know about amputation, but they never think about their vision, right? And we know based on our data that Latino and Black patients are 2 to 3 times more likely to lose their vision due to diabetes, right? So again, what are we doing at Genentech is trying to increase this awareness and campaigns about their vision. We have an external council that we work with closely that focuses on diversity and inclusion. And this external council is made up of oncologists, ophthalmologists, neurologists, and patient advocacy groups. And they really advise us on what are those key messages. You know, I heard in the earlier sessions, it's not just enough to have Google Translate the information, right? We really need to make efforts and make our materials culturally sensitive and really make those translations resonate with our Latino community. One of our external council members is here from DC, Dr. Fabian Sandoval. And maybe if you're from the DC area, you've seen his show, Tu Salud, Tu Familia. And he talks about these issues. He talks about diabetic macular edema, about clinical trials, cardiovascular, to educate the community. What are those symptoms? What should you be looking for? What questions should you be asking your doctor? And all of this comes down to that piece of importance of educating our community and beyond just our patients.
That's great. Now we're also, and we've alluded to this, you, Veronica in particular, have alluded to this a little bit, but I wonder if each of you might share. We're having this conversation in Washington, D.C., the seat of government for the United States. And so I'm wondering, what are your thoughts? What's your advice? What's your guidance for the policy community? What other aspects, in what ways can government perhaps play a role in helping to address some of these issues, right? And helping to support advances in innovation, helping to support, certainly, ideally, bringing costs down, increasing access, right? And maybe even, are there areas where, for example, government could partner and or encourage the private sector, for example, to increase diversity, right, in its clinical trials, increase diversity in its research, et cetera? What are your recommendations for the policy community?
Well, for Amgen, I think that, you know, what this boils down to is representation, right? We talk about that a lot, but it's real, right? This is something to start having activity and actual progress on rather than talking about it. I think that's a lot of what people get frustrated with, is that we're not taking action. Part of the United States being so amazing, right, is that we have this incredible array of diversity. We have an incredible array of races, ethnicities, languages, experiences, but the number of Hispanics, particularly in Capitol Hill, is extremely low. So Amgen's really been in a long-term sponsorship of CHCI's amazing congressional internship program, because we really feel like those opportunities to allow for Hispanic and Latino college students to get that experience have opened the doors for them to have jobs on the Hill, to be part of advocacy organizations where they're leading the way to address health equity issues for Latinos, which is really important that there's representation right where these decisions are made. And of course, I'm going to talk about clinical trial diversity, right? Representation for that is what I live and breathe. So Amgen really advocates for policies that address financial and technological needs for patients. And one really good example for that is the Diverse Trials Act. This is bipartisan, it's bicameral, sponsored by Congressional Hispanic Caucus members, including Senator Menendez and Congressman Ruiz. And this really creates safe harbors so that we can provide free digital health technology to clinical trial participants, including for decentralized clinical trials. And it creates a safe harbor for us to provide for patients that might have some financial barriers to joining a clinical trial. So from that perspective, from a policy perspective and the kinds of sponsorships we're providing, that representation gets really put into paper, but also into action.
That's great.
Yeah, I mean, I touched on this a little bit earlier, but GRAIL is supporting, you know, this Multi-Cancer Early Detection Screening Coverage Act, which will do a couple of really critical things. The first is to establish MCED, this multi-cancer early detection, as a new category that can be you know, a benefit category for that, and then it will also enable CMS to make coverage decisions on the basis of doing this. And the evidence basis that they can use there is something that we're keenly involved in trying to make sure that we do have a diverse representation of the patients that we're including in our studies. Not only our clinical development studies, but also our real-world evidence studies to understand how does this actually work among patients who are getting access to this technology that would be available for them. It is, at this point in time, it has broad support in both chambers of Congress, and so we're hopeful that something like this can move forward because it allows us, again, kind of we're on the stage here, we're representing sort of two distinct ends of the treatment paradigm, right? The early screening and detection, and then the later portion of therapeutics that can be applied for all of that. And if we as an industry are learning to work well with government to ensure that there is adequate support for appropriate policy decisions all along this continuum, it has a better benefit for all of the patients who would be involved. And again, if we're engaging these patients and researchers involved in these sorts of studies, then the programs that we're enabling will obviously be tailored really to those communities that need them.
You know, I just want to add, because I think Raquel and Michael covered it, right? But just the expansion piece that I want to add is, where does policy come into place? I really think from a perspective of industry and policy is what Raquel mentioned. How can policy be changed to allow that clinical trial access? Right now, as industry, we cannot provide or are inhibited by policies to say we'll reimburse patients for their time, we'll reimburse patients for parking. We know that our Latino community, most of us do not have the privilege that I do to be on a salary-based job, that I can say, I'm going to go and participate in clinical trials. I have time off to do that. When I tell my family go and participate, the first thing they're like, Veronica, you're crazy. That means I have to not show up to work and I can get fired, right? That's what the policy side needs to understand. There has to be a medium where we meet halfway and say, how much can we provide? Because it's important for the patient. At the end of the day, all of us are patients. If we put ourselves in that patient's shoes of, if I'm going to participate in that trial, I'm going to give up my time, I need to be compensated for it because that is the right thing to do. In addition, the other side, that needs to be considered is our government needs to be more open to listening and learning from each other as well as industry. With Cancer Moonshot, we have the privilege at Genentech to be part of some of conversations and sharing what we understand, what our learnings are about diversifying clinical trials. What are our challenges? What are the barriers, right, that we are learning? But that dialogue needs to be present. It's not going to be enough for industry, for us to be up here, or Genentech to say, we're going to fix the problems, but because we can't. We cannot fix societal problems. It's going to take a village, a true village, where all of us come together. The patients, industry, don't forget about the payers, the hospitals, legislators, and policy, because everyone really has to take the patient and say, we are doing this because all patients matter, and equitable healthcare should be a right in the US.
That's great. Thank you. Thank you each for sharing those things. I do want to mention to folks that you all should start thinking about whether you have questions or comments you want to share. We're going to move to the open dialogue portion. We're going to move to our Q&A in just a couple of minutes. I just have a question or two, perhaps more, to ask the panel, and then, like I said, we'll open it up to you all. And I believe we may have a microphone. We will have a microphone available for you all to ask. And a couple of things, if I may mention before I ask this next question. One, I do want to thank you, Raquel, for you earned your extra monedita, as we say in Spanish, for the comment, for helping us do a sort of a shameless plug for the work that CHCI does. But truly, this question, this point of representation is really crucial. I mean, I think you've alluded to, in essence, sort of why we have this event and why CHCI exists, because a key factor in all of these conversations, all of these issues, not just in this session, frankly, everything we've been talking about, is this question of whether or not there are enough of us at the table making the decisions about how we proceed as a society. about what sort of laws and policies we create, about where we dedicate and focus our resources, right? About how we allocate our time, and in fact, how we share information and educate the broader public, right? And I think it's not a large leap to sort of figure out that sort of Latinos have been underrepresented in clinical trials, and there hasn't been enough resource investment or information sharing in Latino communities because the people making decisions about how we go about that, whether as government in policy or leadership in the private sector, frankly, doesn't have enough representation from our communities. And so I really wanted to double down on that point, because in essence, again, that is part of the goal and the essence of what CHCI does in our programs, specifically to help support emerging leaders, to help them move faster along that track to be into those influential leadership positions to be able to make decisions. And then coming back around to my this one question I wanted to ask, as Raquel mentioned as Veronica mentioned once again just now, I'm a firm believer as well that to really solve these intractable issues, these deep, complex issues, it's something that can't be solved by government alone. It's not something that can be solved by the private sector alone. It really does take sort of all players, all sectors, all stakeholders, and the community itself as well, in the nonprofit world for sure, whether it be researchers or academics or advocates, all playing a role together. And so the one question I'm wondering before we move to audience participation is, where might there be bright spots that you all can think of? Are there things, are there efforts, are there initiatives that your, and by the way, I want to mention that speaking of your individual corporations and the entities that you represent, Amgen, Grail, and Genentech have been great partners of CHCI and supporters and show your commitment to the community. And so I'm wondering, are there programs, are there initiatives, are there efforts that you've seen either at your organizations or that the community has brought to the attention of your organizations that are making progress, that are showing, again, best practice, where we can see models that should be scaled, that should be expanded, that should be codified, that are things that we can cling to that can sort of maintain hope, again, because sometimes really seeing sort of some of this data around the health indicators for our community can be fairly daunting. So I'm wondering sort of what positive news might each of you have to share that folks can think about, learn more, and build on.
So the great thing about industry right now, particularly at this present moment, is that as a whole, they're really dedicated to making strides towards health equity. I think there was a lot of talk about in the past, maybe there were a few companies that were interested in it, but as a whole, and I think Veronica would probably agree with me, we're part of multiple collaborations through Transcelerate, through CTTI, through DIME, pharma, all of these very large collaborations were all working together to find these solutions. That wasn't as distinct for what we're talking about regarding representation, regarding clinical research, as it was until now in the past year, I would say, or two. So that's something positive to know, that industry is actually trying to collaborate as much as possible, because we're taking the resources we all have to share together to find solutions, which I think is a really bright spot for the work that I do, obviously, but for industry as a whole.
That's great.
Yeah, I don't know, Veronica, if you wanted to say something, but go ahead.
Okay, I'll take it. I'll be brief. No, one of the things that it comes to mind as far as positives, right? One thing that we're doing at Genentech is we're really trying to we brought together a Advancing Inclusive Research Site Alliance. And this is talking about those best practices. And this is a pilot with 4 of the top oncology centers in the country: Mace Cancer Center in San Antonio, City of Hope in LA, I'm blanking, right? University of Alabama, West Cancer Center in Tennessee. And the reason we brought them together was because they're very good at reaching out and doing community engagement in Black communities and Latino communities, bringing patients into their clinical trials, but most importantly, retaining them, right? So from this pilot, sharing those best practices, what is it that these institutions are doing? What can we learn and share with our broader sites? Because between, I think, the 3 of us, we have probably a very good number of sites and principal investigators that we work with. And how can we share that to really increase truly that representation that all of us are aiming for? So just in the sharing, like Raquel said, partnering with larger organizations, I think is key.
Yeah, I mean, sort of as a direct response and to complement the, the answers that have been given here, I joined Grail a couple of years ago. This is a company that's about 6 years old right now. So in contrast to Genentech and Amgen, which have been around for a long period of time. And as sort of a tangible example of signs of hope and how things are changing, it was really informative for me, having worked on the therapeutic side prior to coming to devices here, to say that this organization, which is as young as it is, was willing to make a tangible investment in population health sciences, which includes health equity, and along with real-world evidence. So it was very exciting to have this opportunity to begin to dig into some of these things against a larger backdrop, which, as we've been talking about, has largely changed and begun to shift. And I think the larger basis is moving from not only investing in healthcare providers that are diverse and able to reach these populations, but also health services researchers, such as what we represent too, to understand the need for changing the paradigms and how we think about asking questions in a manner that is relevant to the patient and populations that we hope to be affecting with all of this. And so there is a great momentum and impetus to change all of these things now. Of course, the hill is very steep. There's a long road ahead of us. But there is definitely a sense that, yes, there is opportunity, and we are beginning to address this a little bit more concertedly across all of the industry to be able to take advantage of both the challenges in front of us and the resources that we can bring.
That's great. Thank you. Thank you each. All right, so we're ready to open the floor for questions, for comments. So I think we have someone right up here up front. Yep, there you go.
Oh, hi. Good afternoon. Jeanette Contreras, the Director of Health Policy of the National Consumers League. I'm glad that, Michael, you mentioned real-world evidence, because my question is, I'd love to get all of your thoughts on the role of real-world evidence on helping us to address health equity and the health disparities.
So yeah, I'm happy to jump into that, initially myself. One of the things that is often, been recognized is that we, as an industry, broadly based, tend to engage in development activities, whether it be for a therapeutic, a medication, or a test or a device, and then bring it to the regulatory authorities to get approval for it to be able to be commercialized in doing that. And the circumstances under which we do those studies and those tests tend to be very constrained and regulated with regard to the amount of information and the analysis that we need to perform to satisfy the regulatory authorities for doing that. And by definition, when we do that, we limit our sample size, we limit the questions that we're asking, we limit the way we look at all of these in a manner that doesn't reflect how it's actually going to be used out among the real populations for that. And so we're trying to shorten the time frame and overlap a little bit as much as possible, and I'm speaking broadly here with regard to all of the efforts involved, to where we can begin asking those real-world questions that are often the really more germane and useful questions about, okay, does this work? Yes, that's one question, but will it work among the people who are going to get access to it? And if we can begin to ask those questions at the same time, enrolling populations who may, because of the limitations that we've talked about in terms of access to these studies, the time involved in doing all of that, might not be able to do that. Can we change the research to get this to people as soon as possible to understand the benefit that it's going to have for them? Because that ultimately is the critical question. Not can it work, but will it work, right? Whether we're talking about a test or medication. And if you have, if you like have a car that can go 0 to 60 in 2.5 seconds or whatever, but then you're sitting in rush hour traffic, it doesn't matter how fast your car can go if when you're in an environment that it's not going to be able to go that fast. The same is true for our medications, our devices. They can have all of these great potentials, but if you're really dealing with certain populations that are not going to get access to them, or not going to be able to use them the way that makes the most sense to them, it really doesn't matter. So if we can begin asking those real-world evidence questions earlier, it allows us then to have a leg up in terms of how we can provide these technologies, whether they be medications, devices, tests, as soon as possible to the people who will benefit the most from them. Does that make sense? Yeah.
I like this question because I'm running into some challenges myself with the work that I do, right? And even finding the data itself that helps me make the decisions to make, right? Yeah. A lot of what the FDA's guidance lately has asked for is that we're developing our clinical development programs with racial and ethnic minorities in mind, right? That there's considerations for them. But it's been hard to do that, I will say, because the data hasn't even been collected for us to make those decisions. We're trying to change that, right? At Amgen, we're doing a lot of work to find the real-world data, to find the epi data that matches what we're looking for so we can make these decisions. But that's a challenge, and something I think to be aware of for people that aren't necessarily familiar with research is that the data and the data collection itself can have some systemic racism built into it because we're not collecting data properly or we're not collecting it at all, which is why the question is really good because real-world evidence should evolve to be that. And I think that we're being pushed from both an ethical way, but also from a data way, from a scientific perspective, to start making that data better so that we can make the decisions that we need to make, which will ultimately impact the patients at the end of the line.
One last comment. As far as when we're talking about real world evidence and generation of that real world data, again, it comes to representation, right? And if you start looking at across the industry, where are we in clinical trial representation and do a report card? I think all of us fail. When we look at the real world evidence generation, again, it's going to fail because we're not, for whatever that reason, and I think that's the $1 million question, how do we get that representation and that pull through? But more so, it's when you have that real world generation data, right? That's where we're trying to talk about and see our comorbidities. Because when we're talking about those pivotal trials that Michael was referring to that go to the regulators, we create such a homogeneous population that is not reflective of the real world population that you're going to treat. And that is a disconnect, right? The FDA's recent guidance is trying to change that. It's a guidance, right? It's going to take time for us to get there. But I think as you could tell from the panel up here, all of us are committed and we're trying to figure out in our own industry, in our own companies, how do we make that happen? I know I could tell you our Chief Diversity Officer, Cleta Highsmith, is a powerhouse at Genentech. She is moving and shaking, from in early stages, right? We need to have diversity and inclusion, not wait until we have that phase 2 study, but really start at the bench. When those R&D researchers are thinking, what is the next target that we're going to be talking about? Really understand the epidemiology, understand the incidence rates, and are there truly genetic differences? What does that mean when you're starting and developing those early research and development programs? Because that's where the difference is going to start. But again, it's going to take us some time to get there.
Great, thank you. Thank you, Nish. I think we have a question over here.
Hi. Excuse me. Hi, my name is Daniel Jones. I'm currently a CCI Clinical Public Policy Fellow. Thank you all for being here and for your remarks, especially on this particular topic in preventing and detecting diseases. And so with that, something that's kind of been on my mind, especially as we're talking about a lack of representation in trials and in data sets that aren't there for underrepresented groups. In terms of advancement in biotechnology and in that field and in the resources and the tools that doctors and hospitals are using to serve their patients, right? How do we keep pace in terms of diversity, equity, and inclusion and acknowledging these groups in the advancement of technology that's supposed to serve these groups when there's not data that shows how best to craft it that way? And a lot of times you're talking about the engineers and people putting it together. They're also, a lot of times we're not in those rooms either. So how do we keep pace with that and advancements in technology in this field?
It's a really good question. I think this goes back to what I mentioned at the beginning of the talk is this community-based participatory research model. It really focuses on putting the communities in the center of how you design them. So already early on in the design, how are we even designing what we're about to make in the future at the beginning? So you're asking your research questions before you've even decided you're going to make anything, right? That's kind of where it starts and where that thought begins. I think that that's an important thing to think about because when you think about things like the digital divide, and if you are interested in innovation or digital things, Michael and I were talking about this in a previous conversation, is that we're developing digital technologies and things that you're talking about innovation and maybe not even thinking about whether or not someone has internet access. Do they even have the money for a smartphone? These are some things also to consider is that when you start thinking about digital solutions or innovations, there's also an analog part of this to understand. that there's still people at the end of it, that they still have to be part of designing what that solution looks like, and that the digital divide gets smaller because we've involved people at the beginning rather than at the end.
Yeah, I mean, it's not easy. The question that you're asking isn't easy, and in part, I think it's because we have to, as researchers, undo a lot of the education that we ourselves have received as we come into this. Because the paradigms that we've learned, the questions that we've asked, the approaches that we have taken were not necessarily built for the populations that we really want to try to address and reach right now. And it's uncomfortable for us to say, well, yes, but I've always looked at it this way, I've always measured it this way, and recognize that in large part that's not going to work for what we're trying to do with these people here. So it's a bit of a humbling thing for us to recognize we have to take off our pointy hats and sit down with people who are actually living the reality, ask the questions and get to know them a whole lot better, understand the people who are engaged with them in delivering the care, and what makes sense to study for them. And so as we begin to learn to do that and become ever more effective at it, through opportunities like community-based studies that are actually out where they are as opposed to requiring them to come into us, we'll learn and we'll get better at it, but it still takes time. It takes time and effort.
But it's never to underscore the importance of engaging your patient advocacy groups early, right? Because that is so important in all of the aspects of all of the development program, because we need to understand, does this technology work? Yeah. Does this make sense? I could tell you when we were working in autism, it was so important for us to have autistic patients, the patient advocacy groups, to say, those colors, even the colors, do not work for us, right? They seem simple, but that makes a difference when you're trying to deliver a new change and a new innovative way of working with the patients.
That's great. We've got time, I think, for one more question over here before we wrap.
Thank you, everyone. Lorena Curi, Bristol Myers Squibb. I just want to say what a treat seeing here 3 Latinos in the forefront of the efforts of organizations that are addressing the need for greater diversity in clinical trials. I think that when it comes to differences that are not always seen and that when are heard usually have an accent, it is even more difficult. So I just applaud everything that you're doing, and I'm looking forward to see more of this. There is a lot that we can learn from other communities, like the Black community, and how they have tried to unify their voice and their needs. Let's keep on doing this. This is a picture moment. Congratulations.
Thank you. Thank you for that. And since it was a comment, we will stand even one more to have a question for our panelists to finish up.
Thank you. I'm Dr. Contreras. I'm a G1 oncologist. I'm actually the Chief Healthcare Officer for Planned Parenthood. As somebody who's enrolled many people in pharmaceutical and other kinds of clinical trials, I want to say that one of the things that we really need to do, which has been shown to be really effective, is we really need to have providers in the community who look like the community. Without that trust, it's not going to happen. And when you ask what policy thing we need to do, we need to make sure that we've got young people who are Latino, Black. Everyone needs to be going to school without the kind of debt that they come out of, so that they can represent the community and then engage in these. Because without the trust of the clinicians, it's just not going to happen. And so I appreciate how we need to take this all the way back, because until we do, we're really not getting anywhere. So I guess it's a comment, I guess it's a question. What are the major pharmaceutical companies doing to help to make sure that we hold, and everybody else, hold our legislators accountable for the fact that we need diversity in our clinical folks out there?
I can speak to this from a company perspective with clinical research, because obviously that's my wheelhouse to talk about. But we do know that clinical trials are less likely to be presented as an option to minority patients if it's not presented by an investigator or a physician that looks like them or speaks like them. We already know this. So your point is really great that you brought that up, because I don't know if everybody knows that that's the case, which is why we're really making sure that we are not only engaging potential and current clinical trial investigators that come from the communities or represent the communities that we're looking to target, but also to train potentially minority investigators to be filling the new class of who's going to be treating our communities. So those are a couple of things that we're working on internally, because we know exactly what you said, that if we don't have providers that speak and look and have shared experiences, patients are the ones that actually suffer from that.
Yes, I mean, and I would echo that just to say that we're trying to do the same sort of things where we have these enrollment targets, for instance, that we're interested in trying to do, but we recognize that to really meet those targets, for doing that from a research perspective, it's incumbent upon us to identify those investigators and researchers who reflect the faces of the community that we're trying to enroll there as well. Yeah.
But it's not only, you know, when we talk about clinical trials, it's not only that PI that needs to be a person of color. It has to be the entire staff, right? Yeah. It's a workforce pipeline issue that we have. COVID, you know, let's be frank, turned everything upside down. We are losing staff, but we need to start training the new wave and the new generation. But how do we do that with our Latino and our Black and our underserved communities, right? Because to be honest, you know, I'm here, you know, telling you, you know, that I have a PhD, a JD, but coming from a farm working family, I could tell you, my dad could tell me how to pick strawberries and how to go out and pick lemons and pack them very nicely, but no one can guide me as to where or how I should navigate the higher education. And where policy can make a difference is investing in our K through 12. Investing in making sure that there are mentors, that we actually go and look. I might bring everyone in this room, go to your local elementary schools, high schools, talk to students. They need to see us, you know, they need to see our faces and actually show that there is representation. Right? You know, when we talk about, because your question was like, what is your institution doing, right? At Genentech, we are committed through this K through 12. We actually have a signature program in South San Francisco because that's where we're based. We've spent over $32 million since 2015 with the South San Francisco School District, where we actually send our researchers. We have over 65,000 hours of community service that has been you know, committed by our employees, but also we provide money and funds to the South San Francisco School Union, where we train teachers. How do you teach science? How do you make those especially those in kindergarten, get excited about dreaming about being the next engineer, the next scientist, curing Parkinson's and cancer? That's where you need to start. And the Future Lab at Genentech has actually, when we track, because we're a data company, we track this, right? Over 89% of the students that go through this program come out and say, I want to go into a STEM career. You know, and that's what we need to do. And we need to do more of it.
Well, I, for one, am extremely glad that we recorded this session because there was an incredible wealth of information that was shared here today. And so hopefully you all have gleaned lots of insights, lots of ideas, lots of great suggestions and learnings. And you can, again, you have the opportunity to go back and to review and to share what you've learned and what we need to do as a community, as a society to address these issues. Please do feel free to share your comments, your thoughts, things that stood out to you on social media using the hashtag CHCI Summit. I want to thank each of our panelists, specifically Raquel Racadio, Dr. Michael Del Aguila, and Dr. Veronica Sandoval. Specifically, let's give them a round of applause. And I also want to thank their employers. I want to thank our partners, the supporters, Amgen, Grail, and Genentech, for their support of fostering this discussion and allowing us to have this platform to really delve into this important issue. And now our plenary is concluded, but if you will, please join us after a short break for one of our 3 breakout sessions that are happening concurrently in just a few moments, and in many ways are an extension, a continuation of different aspects of the conversation we've just held. One is actually going to be specifically on the persistent need for diversity in clinical trials, so you'll be able to dive even more deeply into that topic. The other is on our children and community, a conversation on vaccines and impacts of COVID-19, continuing to explore how we respond to the pandemic. And finally, the third session being advancing obesity care and building comprehensive health in Latino communities. So those are in the 3 breakout rooms, and then we'll regroup here for our closing plenary at the end of the day. Thank you very much, and have a good afternoon.